Hello and welcome to the video. Today I'm going to be talking about understanding respiratory failure management. This video is designed to follow on from the previous video where I talked about understanding oxygenation in terms of the pathophysiology and the clinical application. If you haven't seen that video, you can watch it on the link below or by browsing through my channel. So without further ado, let's get right into it. We previously talked about the physiology of the respiratory system in terms of the mechanics involved in bringing air in inhalation and breathing air out in exhalation. We talked about the fundamental difference between hypoxic respiratory failure and hypercapnic respiratory failure. And we talked about important physiology concepts such as the AA gradient and the alveolar gas equation. We also briefly talked about the principles behind how a pulse oximeter works and how the SpO2 correlates with the PaO2 through the oxygen hemoglobin dissociation curve. Now that we have this background, we can go into the causes of type 1 and 2 respiratory failure and subsequently how to manage them. As we mentioned previously, type 1 respiratory failure is an oxygen extraction problem where there is a defect somewhere along the respiratory tract starting from the nose and the mouth all the way to the level of the alveoli, the respiratory epithelium, and even the interstitial space between the alveoli and the blood. By understanding this respiratory tract, we can think about all the possible defects along this respiratory tract that may be possible causes for type 1 or hypoxic respiratory failure. Starting in the upper airways, you can have hypoxic respiratory failure if there is some form of obstruction, although this is relatively uncommon and would have to be quite severe obstruction in order to cause significant respiratory failure. The oral nasal cavity is relatively large, and so pathologies like sinusitis or nasal polyps would have to be really severe in order to cause enough obstruction to cause significant hypoxia. Going down to the level of the pharynx, there's a much more common cause of hypoxia, that being obstructive sleep apnea, which is thought to be due to increased compliance of the pharynx and increased collapsibility leading to potential hypoxia. Further down at the level of the larynx, you can get pathologies such as laryngospasm or laryngeal edema, which will therefore cause obstruction and hypoxia as well. Even lower at the level of the trachea, you can get pathologies such as tracheostenosis or tracheomalacia. But again, this would have to be pretty severe to cause significant obstruction and thus hypoxia. Anywhere through these larger airways, you can also get foreign body obstruction, which can then cause blockages and therefore hypoxia. But the much more common pathologies that we'll see in clinical practice are that of lung pathologies. Common structural lung problems include that of emphysema or bronchiectasis, where there's a decreased amount of normal respiratory epithelium and therefore reduced ability to participate in gas exchange, leading to hypoxia. You can also have hyperreactivity and constriction of larger and smaller airways in diseases such as asthma, which therefore will reduce the amount of airflow in and out of the lungs, which will also cause hypoxia. You can also get direct damage to the parenchyma, most commonly from an infective process known as a pneumonia, where you get consolidation, which directly affects the alveoli and the surrounding parenchyma, leading to reduced gas exchange and hence hypoxia. You can get fibrotic lung disease, where you get fibrosis of the interstitium between the alveoli, which over time then leads to destruction of the alveoli itself, therefore leading to reduced gas exchange and hypoxia. In pathologies with increased pulmonary venous pressure, such as heart failure or pulmonary hypertension, you can get increased fluid accumulation in the interstitial space and a widening of this space, which therefore impairs the gas exchange process between the respiratory epithelium and the pulmonary circulation. In rare cases, you can get pulmonary hemorrhage, which can lead to blood filling up the alveoli and impairing gas exchange that way. You can also get a number of organisms which cause what is referred to as an atypical lower respiratory tract infection, which have a predilection to affect the alveoli and cause alveolar infiltrates. These include things like tuberculosis and fungal infections. Although there are a number of different organisms which can cause lower respiratory tract infections, and they tend to have their own specific clinical and radiological features. You can also get a severe form of respiratory failure known as acute respiratory distress syndrome, or ARDS, where there's a severe inflammatory infiltrate and reaction between the respiratory epithelium and the pulmonary circulation at this level of this interstitial space here. So as you can see, there are numerous pathologies that can occur anywhere along the respiratory tract that can all lead to ultimately impaired oxygen exchange and oxygen extraction, which therefore leads to hypoxic respiratory failure. All of these pathologies discussed impair the ability of oxygen to be extracted from the alveoli into the blood. Now, getting oxygen to this level where it can then be absorbed into the blood is one part of the process. The other part of the process is that there must be enough perfusion of blood to these alveoli that are being ventilated, because the blood carries the deoxygenated hemoglobin that is able to get to the alveoli and flow past it to pick up the oxygen to then become oxygenated hemoglobin and then travel to the rest of the body to be able to deliver the oxygen for aerobic metabolism. And so we can see that not only is the ventilation process important in getting oxygen all the way to the level of the alveoli so it can be absorbed, the second perfusion process is also important, because this is what actually delivers deoxygenated blood to the alveoli so that it can then pick up the oxygen and then take that to the rest of the body. So these two processes, known as ventilation and perfusion, are usually matched in order for the respiratory system to work properly. It follows that if there is a mismatch in the ventilation and perfusion, or the V and Q, there will be ultimately relatively lower amounts of oxygenated hemoglobin, and therefore the patient will be hypoxic and in hypoxic respiratory failure. We've talked about the range of ventilation defects that can occur along the respiratory tract and lead to reduced oxygen getting to the alveoli. We can also get perfusion defects, namely that of a pulmonary embolism, which will lead to reduced blood flow distal to the clot, and therefore reduced delivery of deoxygenated hemoglobin, which therefore leads to less oxygen being able to bind to hemoglobin and therefore less oxygen delivery and hypoxic respiratory failure. So now that we understand this concept of VQ match, or ventilation and perfusion match, you may then wonder, how is it that patients with underlying lung disease such as emphysema in chronic obstructive pulmonary disease maintain VQ match when their ventilation is always compromised? Well, the answer lies in the body's amazing mechanism to maintain VQ match through something known as pulmonary hypoxic vasoconstriction. The principle here is that poorly ventilated lungs must also be poorly perfused to maintain VQ match, and by not perfusing poorly ventilated lungs, blood can be diverted to well-ventilated lungs to then maintain VQ match that way. This explains why underlying lung disease, whether it be restrictive lung disease from things like interstitial lung disease or obstructive lung disease such as things like chronic obstructive pulmonary disease, both lead to significant amounts of chronic hypoxic pulmonary vasoconstriction. And as the name implies, the vasoconstriction leads to increased pressure within the pulmonary vasculature and therefore over time leads to pulmonary hypertension, and more specifically in the setting of lung disease, group 3 pulmonary hypertension by the World Health Organization classification of pulmonary hypertension. Understanding this concept of pulmonary hypoxic vasoconstriction is important because it explains why it can be dangerous to over-oxygenate patients with underlying structural lung disease or reasons to have hypoxia, such as in emphysema or chronic obstructive pulmonary disease. In these patients, they will have regions of emphysema which have poor gas exchange and are poorly ventilated, for which there will be relative vasoconstriction for those areas of lung so that blood does not go to those poorly ventilated areas and goes to areas that are well perfused. However, by over-oxygenating these patients, you then ventilate areas of lung which are normally not well ventilated, and this can lead to a reversal of the pulmonary hypoxic vasoconstriction that is normally physiologically adaptive, which therefore leads to redirection of blood more towards areas which are normally poorly ventilated because they are poorly functioning, and therefore less blood going to the normally well-functioning areas of lung. Overall, this leads to a VQ mismatch and can worsen hypoxia. So that wraps up type 1 respiratory failure. Now let's talk about type 2 respiratory failure, which is fundamentally different in that instead of being an oxygen extraction problem, the primary problem is in the respiratory or ventilation mechanics, leading to an impaired ability to inhale and exhale, which subsequently leads to hypoxia and hypercapnia respectively. Causes of compromised ventilation mechanics can include muscular weakness of the diaphragm in pathologies such as myasthenia gravis or phrenic nerve palsies, or other various neuromuscular or congenital disorders. There can also be reduced ventilation or hypoventilation associated commonly with obesity, known as obesity hypoventilation syndrome, or there could be pharmacological effects leading to reduced ventilation or hypoventilation, namely from drugs such as opioids. The other major problem that can compromise ventilation mechanics is that of a restrictive pathology on the thoracic cavity. That can include things like chest wall deformities or spinal deformities such as kyphosis or scoliosis, and more commonly but often under-recognized, that of obesity, where significant adipose tissue surrounding the chest wall can lead to a reduced ability for the chest wall to expand. And that basically sums up type 2 respiratory failure causes. Now that we've talked about type 1 and type 2 respiratory failure etiologies, we can now move on to talk about how to manage these conditions. As a general rule in medicine, you should always try and treat the underlying cause. And so, if you've been able to identify an etiology for the respiratory failure, you should try and treat that cause. For example, in type 2 respiratory failure, if the cause is myasthenia gravis, you need to treat the myasthenia gravis. If the cause is severe chest wall or spinal deformities, then perhaps the only way you can improve this is with surgical intervention and surgical correction. But in the acute setting, when patients are in type 2 respiratory failure and have started to retain carbon dioxide, of which the side effects are worsening drowsiness and acidosis, which can lead to a coma, the acute management involves trying to help the patients ventilate through non-invasive ventilation, namely BiPAP or bi-level positive airway pressure, and in more severe cases, intubation and mechanical ventilation. I will later discuss why using BiPAP is preferred over other modalities like CPAP and high-flow nasal prongs. The same principles apply for type 1 respiratory failure, where there can be a range of different causes, and the investigations should be targeted to trying to identify the cause of hypoxia and then treat that underlying cause. So commonly, if the patient has a pneumonia, you need to treat the pneumonia with antibiotics, and if the patient has pulmonary edema from congestive heart failure, then the patient should be diuresed with furosemide. However, in the acute setting, when the patient is hypoxic, the treatment for the hypoxia is supplemental oxygen, of which there are a number of different modalities available to the clinician, which have slightly different functions and therefore different roles in treating different types of respiratory failure. Going through these modalities, we have at the most basic level nasal prong oxygen, which can be delivered at a flow rate up to about 6 liters per minute reliably, giving an FiO2 reliably up to about 35 to 45%. You can also use a Hudson mask, which is used for higher flow rates from about 6 to 10 liters per minute, which can deliver an FiO2 up to about 55%. You can also use a non-rebreather mask for even higher flow rates of around 10 to 15 liters per minute, which can deliver an FiO2 up to about 80 or 90%. Or you can use a separate apparatus known as high-flow nasal prongs or high-flow nasal cannula, which essentially delivers humidified air at a very high flow rate, up to about 60 liters per minute, and a similarly high FiO2. In more severe respiratory failure, you may need to use non-invasive ventilation via positive airway pressure machines, of which there are two main types, that of continuous positive airway pressure, or CPAP machines, and that of bi-level positive airway pressure, or BiPAP machines. As their name implies, the main difference is that in CPAP there's a continuous single set level of pressure. That is the same pressure delivered throughout the respiratory cycle, whereas in BiPAP there's an inspiratory pressure and a lower expiratory pressure. This difference is useful to know because in pathologies which are purely hypoxic, or in pathologies where there's reduced compliance of the pharynx and you need to keep the pharynx open to prevent it from collapsing, such as in obstructive sleep apnea, CPAP is ideal for these situations because it delivers a constant single pressure throughout the whole inspiratory cycle, and therefore, as long as this pressure is adequately titrated, the pharynx, which is normally would collapse, is able to be kept open, and therefore hypoxia is prevented if this is the underlying etiology. In contrast with BiPAP, by having a lower expiratory pressure, you're able to allow the patient to breathe out a bit better, which is useful in hypercapnic respiratory failure because it is the exhalation phase where carbon dioxide is breathed out. With the BiPAP machine, you can then maintain a high inspiratory pressure to then allow oxygen to get in and fix the hypoxia. And lastly, there is mechanical ventilation, which is essentially a breathing machine which you can put patients on who are intubated. The modality of choice depends on the underlying etiology and the severity of the respiratory failure. In most situations of mild to moderate hypoxic respiratory failure, nasal prong oxygen is appropriate. A good rule of thumb is that for every 1 liter per minute increase in flow rate, you increase the FiO2 by about 3 to 4%. And so at room air, your FiO2 is 21%. With 1 liter per minute nasal prong oxygen flow rate, you get an FiO2 of about 24%, and with 2 liters, 28%. Although it may seem like giving 1 liter and 2 liter per minute nasal prong oxygen is not a lot, if you go back to the alveolar gas equation, you can see that increases in FiO2 can lead to substantial increases in alveolar oxygen. Here are a set of calculations for the alveolar gas equation, with the first set being under normal circumstances where you have a FiO2 of 21%. You can see here that this leads to a PaO2 of around 100. Now, assuming the PaCO2 stays the same, which it should unless the patient is severely tachypneic, you can see that simply increasing the FiO2 from 21% to 24% leads to an increase in the PaO2 to about 121. And when you then increase it to 28%, you then increase the PaO2 to about 150. And so just by going from 21% in room air FiO2 to 28% FiO2 in 2 liters nasal prongs, you effectively increase the amount of oxygen in the alveoli by about 50 millimeters of mercury. Of course, if you have an oxygen extraction issue, you'll have an increased AA gradient, and not all of that extra 50 millimeters of mercury of oxygen that you're delivering to the alveoli will be able to get into the blood. But say even if your AA gradient was increased to say 50 and your PaO2 is 150 because you're giving 2 liters per minute flow rate of nasal prong oxygen, you would therefore expect the arterial pressure of oxygen to be 100, because if you have an alveolar pressure of oxygen of 150 and an arterial pressure of 100, that would give you a AA gradient of 150 minus 100, which would be 50. With an arterial pressure of oxygen of 100 millimeters of mercury, you would expect the oxygen saturations to be close to, if not 100%. As this is on the right side of the oxygen hemoglobin dissociation curve, and 100 millimeters of mercury is substantially more than 60 millimeters of mercury, which correlates to 90% SpO2 and is the cutoff for hypoxic respiratory failure. So going back to our modalities, you can see why nasal prong oxygen works for most of the mild to moderate cases. However, if the patient is acutely deteriorating on the ward, usually the first thing you can give to have higher flow rates are that of a Hudson mask or a non-rebreather. And if the patient remains hypoxic, you then need to transition the patient to a higher level modality. These modalities include that of high flow nasal prongs, BiPAP, of which you can use it for type 1 respiratory failure, but it is particularly useful for type 2 respiratory failure, CPAP, which can be useful for type 1 respiratory failure, but generally you wouldn't use it for type 2 respiratory failure, and lastly, mechanical ventilation, for if the patient has such severe respiratory failure that it is refractory to all of these other modalities, or if the patient is losing consciousness and losing their airway and they need to be intubated and therefore mechanically ventilated. I'll now like to finish the talk by talking about oxygen dilution and the role of high flow nasal prongs. To understand this, we have to understand the concept of minute ventilation, which is a product of the respiration rate multiplied by the tidal volume. Conceptually, this can be thought of as the total amount of air that we breathe in 1 minute. So let's just assume that we have a tidal volume of around half a liter or 500 mils, which obviously depends on the patient's size and height, but for the purposes of this, we'll use a nice easy number like 0.5. And let's say the patient has a rest rate of 12, which is pretty normal, which will give us a minute ventilation of 6 liters per minute. Now the previous FiO2 estimations are based on the assumption that the patient is breathing relatively normally and has a relatively normal minute ventilation. So you can really only assume you're giving the patient an FiO2 of 28% on 2 liters nasal prongs if they have a relatively normal minute ventilation. A patient in severe respiratory failure may have a respiration rate of 40 breaths per minute and a tidal volume which increases up to 800 mils, giving them a minute ventilation of 32 liters per minute, which is more than 5 times greater than what would be considered a normal minute ventilation. In a patient with a normal minute ventilation, who is breathing in 100% oxygen from the wall supply nasal prong oxygen at a 2 liter per minute flow rate, the estimated FiO2 delivered of 28% would hold true, because in this situation, the minute ventilation of 6 liters per minute is roughly matched to the flow rate of the supplementary oxygen at 2 liters per minute. Now, going back to our patient with severe respiratory failure and a minute ventilation of 32 liters per minute, if you then give this patient nasal prong supplementary oxygen at a flow rate of only 2 liters per minute, even though that oxygen that's coming from the wall is 100% oxygen, it would be mostly breathing in room air rather than actual supplementary oxygen, because their minute ventilation is so much greater than this supplementary oxygen flow rate. This is known as oxygen dilution, and therefore the estimated FiO2 that is actually being delivered is much less than the predicted 28% and would be much closer to room air at 21% FiO2. These are the precise situations where high-flow nasal prongs become very effective, because the high-flow nasal prongs, as its name implies, are able to deliver very high flow rates, up to 60 liters per minute. And so in this patient in severe respiratory failure with a minute ventilation of 32 liters per minute, you can easily start the patient on high-flow nasal prongs at, say, 40 liters per minute, which is a flow rate that exceeds the patient's minute ventilation. And you can also set the FiO2 as well, which is in most situations roughly the same as the flow rate. And so if the FiO2 is set at 40% and you're giving them a flow rate of 40 liters per minute, you can then be reasonably confident that you are actually delivering the prescribed amount of FiO2, so 40% in this situation, and therefore you are adequately treating the patient's hypoxia. It also follows that the main reason why patients need to stay on high-flow nasal prongs is because they have an elevated respiratory rate, which is the main driver for a high minute ventilation. So say the patient has hypoxic respiratory failure and you keep them on high-flow nasal prongs and they start to improve after a few days, assuming their tidal volume gets back down to half a liter and their resp rate is less than 20, that would give them a maximum minute ventilation of 10 liters per minute. In such a situation, you do not need to give patients 40 liters per minute via high-flow nasal prongs, and you should be able to step them down to normal nasal prongs. Generally, a respiration rate consistently less than about 20 is a sign that the patient will no longer benefit from the very high flows that are generated from the high-flow nasal prong apparatus and should be able to at least trial a step down to nasal prong oxygen. And that brings us to the end of this video. I hope you now have a better understanding of respiratory failure, the differences in the underlying etiologies and treatment. Here is a slide of the key take-home messages that we've discussed throughout this video. If you like this content, please leave a like, comment, and subscribe to the channel. All the best.